Welcome to the Deep Dive, the knowledge shortcut that distills complex research into critical understanding. If you look at the news cycle, violence, whether it's domestic, community, or self-directed aggression, it's sadly a constant theme.
And that reality places nurses, particularly those in psychiatric and emergency settings, right on the front lines of prevention and, well, crisis intervention. Today, we're taking a shortcut through a foundational chapter on anger, aggression, and violence, looking at the assessment, the science behind it, and the specific intervention strategies needed to keep patients and, crucially, staff safe.
That's our mission. But before we get into the complex brain science and stuff, we really have to start with the language. Because in a clinical setting, knowing the difference between these three core concepts, that's the crucial first step.
Absolutely crucial. Let's unpack this.
Okay. So where do we start?
We begin with anger. Now, this is the emotion.
Yeah.
It's a completely normal human response to frustration or to a challenge or, a perceived threat, whether that threat is physical or maybe emotional.
Right.
What's really important to remember here is that anger isn't inherently bad. The sources actually note it can be positive when it motivates productive action, like exercise or art.
Okay, so anger is the internal feeling, the raw emotion. What's the next step up from that?
That would be aggression. Aggression is the action or the behavior that results in some kind of verbal or physical attack.
Okay.
Now, this is key for practitioners. Aggression isn't always inappropriate. Sometimes, it's needed for self-defense or protection.
Ah, okay.
But when we talk about violence, we are talking about something different. It's always an objectionable act. Violence is always intentional, involving the use of force that results in, or importantly, has the strong potential to result in, injury.
Got it. So violence is where the behavior crosses a line, becomes clinically unacceptable.
Precisely. That's the critical distinction.
And this isn't just abstract risk management for nurses, is it? The source material is pretty blunt about the dangers.
It is brutally clear, unfortunately. Because nurses have the most direct patient contact, they are frequent targets of violence, especially in those high-risk zones we know about, like emergency rooms, psychiatric units, ICUs, and geriatric care settings.
So knowing the stuff isn't just academic, it's fundamentally about ensuring your own safety and the safety of everyone on the unit.
It's tragic, but it's true. When you're assessing someone in these settings, you aren't just, reading a textbook chapter. You are actively trying to make sure you get home safely that night, too. This isn't abstract theory at all.
Okay, let's jump into section 1 then. Understanding the roots. We often focus on the immediate psychological triggers, maybe the situation itself, but anger and aggression have surprisingly deep biological roots.
They absolutely do. We see anger and hostility studied widely in the context of conditions like PTSD and substance use disorders. And what's fascinating here is the comorbidity. Chronic hostility is actually an independent risk factor for really serious physical health issues, things like hypertension, cardiovascular disease, and chronic illnesses that might require frequent hospitalization. The emotional state truly impacts the body long-term.
Wow. And it starts even deeper than that genetically, right? I was surprised to see the mention of the MAOA gene. What are the key biological markers driving this sort of predisposition?
Yeah, the science shows that a modification of the monoamine oxidase A, or MAOA gene, is associated with aggressive tendencies, but usually only when that genetic factor is coupled with challenging environmental factors.
So it's that classic nature and nurture interaction.
Exactly. They work together.
And that biological predisposition gets routed through the brain's central command center for emotion, the limbic system. Let's focus on the brain circuits here for a moment. We know the amygdala recognizes threats and kicks off the fight or flight response, but the research offers something kind of counterintuitive about its structure.
Yes. This is where it gets really interesting. The actual size of the amygdala is inversely related to aggressive responses.
Wait, smaller means more aggression.
Smaller size means you are statistically more likely to respond aggressively when challenged.
Yeah.
Which tells the nurse, in the moment, this isn't always a conscious choice for the patient. This is sometimes about their hardware, their wiring.
Right, right. And closely connected is the hippocampus, which handles memory and has also been linked to social aggression, particularly in, some early animal studies. Then you have the prefrontal cortex, the brain's executive branch, the CEO, basically.
That's where the brake pedal is supposed to be, yeah. The prefrontal cortex is responsible for that executive function, assessing consequences, and importantly, suppressing unacceptable behaviors. Deficits in this area are pretty consistently linked to the anger-related aggression we sometimes see in conditions like borderline personality disorder and also in some individuals with schizophrenia.
And it's also a delicate balance of chemicals, isn't it? Neurotransmitters. Which ones are playing the biggest role in either, like, enhancing or inhibiting aggressive responses?
Well, serotonin is complex.
Yeah.
It can actually inhibit or stimulate aggression depending on the context. Dopamine impacts reward seeking and can enhance aggressive responses sometimes.
Okay.
But the main inhibitory chemical we often look at is GABA. Reduced levels of GABA are highly correlated with increased impulsivity and aggressive reactions, which can make intervention that much harder.
Okay, so shifting gears a bit, away from biology to learned responses. Psychoanalysts like Menninger suggested that a fundamental human drive is the struggle for control. When a patient feels that control is threatened, where does that tend to lead?
When control is taken away or feels threatened, it often triggers trauma, which then leads to anger and potentially violence. This ties directly into cognitive appraisal, a concept championed by Aaron Beck. Anger results not just from perceived physical danger, but also from threats to our values or beliefs. Think about the patient who's been waiting a long time. They don't usually think, oh, the staff must be really busy.
Right.
They might think my time isn't valued or they don't respect me. That appraisal escalates the anger.
Which feeds perfectly into social learning theory, right? Bandura's idea that we learn aggression by observing and imitating others, especially if that aggression seems to be rewarded or, crucially, just goes unpunished.
Exactly. If, say, television violence rarely shows negative consequences, it inadvertently models aggression as an effective way to solve problems. And that's a powerful lesson, especially for vulnerable individuals.
That deep understanding, from biology to learning, brings us directly to the nursing process. We need to be able to spot those observable cues before the situation explodes. What are the key behavioral signs of escalating anger?
The general assessment relies on looking for things like increased irritability, frowning, maybe clenching of the fists or the jaw, a rigid posture, and of course, verbal abuse like profanity. However, the most important predictor of imminent violence, the thing to really watch for, is hyperactivity, specifically pacing and restlessness.
Pacing and restlessness, okay.
Any significant change from the patient's usual baseline behavior should be addressed immediately. Also, watch for things like stone silence or really intense, unwavering eye contact, or, conversely, the complete avoidance of eye contact.
We've talked about pacing, eye contact, those behavioral cues, but is there one single assessment factor that rises above all others in predicting imminent danger? What's the clinical gold standard here?
The single best predictor of future violence is absolutely a patient's history of violence.
Okay, history.
That's the most important indicator you have. And building on that history, we really must fully integrate trauma-informed care into our approach.
Right, that's become much more central recently.
Yes, and it's crucial. We need to recognize that disruptive patients often have histories of violence or victimization themselves. And this background severely impedes their ability to self-soothe or regulate their emotions. Care has to focus on understanding and addressing these past experiences.
So once we assess that risk, using history and current behaviors, how do we translate those observable cues into a clear nursing diagnosis and set some concrete care goals?
Okay, so if we see hyperactivity like that pacing, coupled with a known history of past aggression, that translates pretty directly into the nursing diagnosis of risk for violence.
Makes sense.
And the outcome goal is direct and simple. The patient exhibits no violence, identifies alternatives to using aggression, and maintains self-control.
And conversely, what if that anger seems turned inward, maybe linked to feelings of hopelessness or despair?
Then the diagnosis shifts, potentially to risk for suicide. In that case, the goal becomes helping the patient safely express those overwhelming feelings and, crucially, refrain from any self-harm. And finally, if the problem seems rooted more in the environment or their current coping skills, we might look at impaired coping or maybe stress overload. The goal there is to help them establish more effective coping mechanisms and reduce those physical symptoms of stress, like muscle tension or rapid breathing.
So once we've understood the roots, assessed the risk, got our diagnosis, the crucial next step is intervening before things escalate further. How do we start building that initial trust, even when a patient might seem volatile?
Yeah, intervention really starts early, ideally before significant agitation. It begins with numerous brief, non-threatening interactions. Maybe just talk about sports or the weather, something neutral, just to establish a basic rapport.
Little check-ins.
Exactly. Then when agitation starts to build, you need to acknowledge the patient's feelings, but also clearly state your expectations for the unit. Something like, I understand you're frustrated right now, but I expect that you will stay in control.
Okay, let's talk safety logistics. This feels like really non-negotiable personal safety advice for staff.
Absolutely crucial. You must maintain adequate personal space. The guideline is roughly 1 foot farther than the patient can easily reach with their arms or legs.
Good rule of thumb.
And critically, you must always ensure you have an escape route. The patient should never, ever be positioned between you and the door. Your safety is paramount.
Okay. And communication itself needs to change when someone's brain is in that fight or flight mode, right? Their ability to process information decreases when anger escalates.
That's exactly right. So you need to adjust. Speak slowly, use short, simple sentences, and maintain a low, calm tone of voice. Avoid challenging questions or saying things like, why are you acting this way?
Right.
Instead, use open-ended, reflective statements that show you're hearing them. Things like, you seem to be very upset, or perhaps, it sounds like you feel people are treating you unfairly right now.
And to combat that core feeling of lost control, which, as we said, often precipitates violence, what's the best technique? Giving some of that control back.
That's a key strategy. Offer 2 clear, acceptable options whenever possible. For example, do you want to go to your room for a while, or would you prefer the quiet room? This simple choice can decrease the patient's sense of powerlessness.
Nice.
And overall, remember the core de-escalation principles from box 27.2 in the text. Maintain the patient's self-esteem and dignity, maintain your own calmness, respond as early as possible, avoid invading personal space, and be assertive, not aggressive.
But sometimes, despite our best efforts with de-escalation and communication, the situation does escalate to the point where safety is severely compromised. That brings us to seclusion and restraint, the absolute last resorts.
They absolutely are. Legally and ethically, seclusion or restraint must be used only when a patient poses an immediate risk of harm to themselves or others, and when no less restrictive alternative is working or available.
So things like verbal intervention, PRN medication, trying to decrease sensory stimulation,
Yeah,
those have to be tried or deemed ineffective first.
correct. And they are never to be used for punishment or just for staff convenience. That's critical.
And the monitoring requirements during seclusion or restraint are pretty exhaustive, aren't they?
They are incredibly strict, as they should be. We're talking constant, close monitoring, usually one-to-one observation, or very frequent checks looking at vital signs, circulation, hydration, nutrition, comfort, range of motion, and their mental state.
Okay.
The orders must come from a licensed practitioner, like a doctor or nurse practitioner. Although in an emergency, they might be applied first and the order obtained immediately after. And crucially, these orders can never be written as PRN or as needed. Each instance requires specific justification and a time limit.
Got it. We also have to consider different patient groups. What about the patient who normally has pretty healthy coping mechanisms but is just completely overwhelmed by the stress of being hospitalized, maybe facing a scary diagnosis?
Yeah, for them, we shift to a more collaborative approach. The source talks about using validation therapy here. Their distress is often understandable, given the circumstances. So the intervention focuses on validating the feeling behind the anger.
How does that work exactly?
You try to name that specific underlying feeling. Are they feeling discounted, embarrassed, unheard, scared, or maybe out of control? Saying something like, it sounds like you feel really unheard right now, or this must feel incredibly scary, often helps the anger dissipate so they can actually engage in problem solving or talking about their fears.
Okay, that makes sense. But the strategy shifts quite a bit for the patient with, say, marginal coping skills, who tends to externalize blame, right? The person who always sees the problem as out there.
Completely different approach.
Yeah.
These patients often see the source of their anxiety as external. It's always someone else's fault. If they become verbally abusive, the strategy is often about setting and maintaining clear boundaries by withdrawing attention from the negative behavior.
How do you do that safely?
You might say, in a very neutral, matter-of-fact tone, something like, I can see you're upset, but I won't be spoken to like that.
Yeah.
I will return in 20 minutes when we can talk respectfully.
Yeah.
And then you calmly leave the room, ensuring safety first, of course. But crucially, you must provide positive reinforcement for appropriate communication when they are calm.
Right. Reinforce the positive. Okay. And finally, perhaps the most challenging population, those with significant cognitive deficits like delirium or dementia. We know that traditional reality orientation, telling them, no, it's Tuesday or your children aren't here, often just increases agitation.
Correct. Trying to force our reality onto someone who can no longer process it usually backfires, increases fear and agitation. Instead, the best approach is often to simplify the environment, reduce noise, clutter, confusing stimuli, establish a predictable routine,
Oh,
and use validation therapy, but in a different way. If a woman insists she needs to go home right now to care for her babies, instead of correcting her facts, you reflect the underlying emotion. You might say something gentle like, "You really miss your children, don't you? Tell me about them." Or, "It sounds like you feel you need to be needed." This establishes trust and calm, making redirection possible.
connecting with the feeling, not the fact. Okay. Let's quickly review the pharmacological management side. For acute violence, when immediate de-escalation isn't possible or hasn't worked, what are the go-to medications?
For acute management, the primary agents usually fall into two classes. Antipsychotics like haloperidol, Haldol, or olanzapine, Zyprexa, and anti-anxiety agents, specifically lorazepam, Ativan.
Right.
Often a combination is used given intramuscularly for faster effect. A common one you might see is haloperidol plus lorazepam. Sometimes diphenhydramine, Benadryl, or benstropine, Cogentin, is added to that mix to help mitigate potential extrapyramidal side effects from the antipsychotic.
Okay, the B52 or variations of it. And what about for long-term management of chronic aggression? What dictates the choice of medication then?
It really depends entirely on the underlying psychiatric disorder that might be contributing to the aggression. We see SSRIs used, sometimes lithium, which is often effective even at lower doses, specifically for its anti-aggressive properties, separate from its mood-stabilizing effect.
Interesting.
Also anticonvulsants, like valproic acid or carbamazepine, and sometimes second-generation antipsychotics are used long-term. However, a key caution mentioned is that practitioners must use SSRIs carefully in patients who also have a comorbid bipolar disorder diagnosis due to the risk of inducing mania.
Good point. And finally, once the immediate crisis subsides and the patient is safe, the work isn't quite done, is it? There's the staff side too.
Absolutely. Critical incident debriefing is considered mandatory, or at least best practice, for staff involved. They need a chance soon after the event to review what happened, evaluate the team response, and process their own very real feelings. Fear, maybe anger, frustration. Addressing the staff's experience and tackling the common issue of underreporting violence is essential for long-term organizational safety and staff well-being. And, importantly, discussion with the patient is also necessary once they're reintegrated to help them understand triggers and plan alternative responses for the future. It becomes a learning opportunity.
So, pulling all this together, what does it all mean for the nurse on the floor? The core mission seems unwavering. Safety, no violence, no suicide.
That's the bottom line.
And achieving that requires continuous assessment, really knowing when and how to deploy those sophisticated de-escalation skills we talked about, and maintaining a deep self-awareness to prevent your own emotional response from ever escalating the situation. It seems to boil down to choosing the least restrictive intervention based on where the patient is right then, in terms of their coping abilities and cognitive status.
Exactly. And this raises, I think, an important question for you, the listener, to maybe reflect on. Given this deep connection we've discussed between past trauma, fear, and that feeling of lack of control often leading to violence, how can a nursing environment, which has to be designed fundamentally for safety, simultaneously prioritize patient autonomy and choice? How do we give back control to prevent patients from feeling threatened enough to escalate in the first place? The fundamental paradox, really, that we have to navigate every single day in these settings.
That is a powerful thought to leave with. Thank you for joining us for this deep dive into anger, aggression, and violence in psychiatric nursing. We genuinely hope this shortcut helps you feel more prepared and well-informed as you navigate these challenging situations.